Good morning and good evening to all our fellow endoscopists all over the world. And welcome once again to this global webinar of East Meets West, where we try to bring together the world of interventional endoscopy. After the success of our first session of this webinar in August, we bring to you today another very contemporary topic of interest, that is of endoscopic mucosal resection. Today's topic is about EMR, when and how, and we are sure that you will all enjoy this webinar. Before I hand over to my fellow course director, Dr. Truptesh Kothari, a few announcements. Please put your questions in the Q&A box rather than in the chat box, so that we can take them up during the session and at the end of the session. And mind you that this is an interactive webinar. We have kept about 25 to 30 minutes for question answers, and we want audience participation. So don't shy away from asking your questions. And we have the best in the field of EMR today to whom you can ask these questions, and I'm sure that you will have your responses and your answers to this. So with this, Truptesh, over to you.
Thank you, Amol, and good morning for our viewers in the West Coast, and especially it's around 8 o'clock right now in the Eastern Coast, and thanks to all the faculties for coming in. We have people from Australia and from Japan at very odd hours as well. So without losing any time, I would like to introduce our esteemed speakers and especially the moderators as well. So we have from our East, Dr. Noriya Uedo, who is the Vice Director, Department of Gastrointestinal and Oncology, Osaka International Cancer Institute in Osaka, Japan. Following that is my mentor, Dr. Gottumukala Raju. He's from the West, representing us. He's the John Strolin Distinguished Professor of Medicine, Department of Gastroenterology and Hepatology and Nutrition at UT MD Anderson Cancer Center in Houston, Texas. Then we have my esteemed friend and a very dear colleague, Dr. Rajvinder Singh. He is one of the moderators representing the East. He's a professor of medicine at the University of Adelaide, director of gastrointestinal and also the department head of endoscopy and interventional endoscopies himself. He also leads the Lyle McElwain Hospital at Adelaide, Australia. And last but not the least is my very good friend, is Dr. Aasma Shaukat. Aasma Shaukat is a professor of medicine, and she's at NYU and also at the Grossman School of Medicine in New York, New York. So without losing any time, I would hand over the platform to Dr. Noriya Uedo. All yours, Dr. Uedo.
Thank you for inviting me to this session. So I recorded my presentation because I don't want to overtime. So can you see my presentation? Okay, I'll start.
Yes.
Thank you, Amol, for inviting me to this exciting session. This time, I am introducing my clinical practice of EMR in Japan. This is a historical background of EMR. EMR was initially intended to obtain large area of mucosa to make precise diagnosis of gastritis. Then, later on, it is used for treatment of mucosal neoplasms. Therefore, advantage of EMR include removal of intramucosal lesion and possibility of histological assessment of resected specimens. There are several methods of EMR. One is simple smearing, with or without injection, and use of grasper to lift the mucosa to cut it, and use of cap aspiration to lift the mucosa and cut it. And another one is use of band ligation to maintain the mucosal lift and cut the mucosa. This is a bit busy slide, but basically we determine the indication and method of EMR according to organ, morphology, and the size of the lesion. But basically we indicate EMR for only small lesions such as 2 cm or smaller, which is about the same size to the snare, except duodenum. This is mainly because we have ESD technique that is covered by social insurance. So we really appreciate unblocked resection of the lesion. The reason why we accepted piecemeal resection for duodenal EMR is because the serious complications such as delayed perforation or septic retroperitonitis overwhelm importance of unblocked resection in the duodenum. But anyway, to determine the indication of EMR, tumor depth and the tumor extent, meaning size, should be assessed carefully. So, in a practice, the lesion characteristic is evaluated in a different endoscopy session before the treatment. We believe, theoretically, if the lesion is confined to the mucosa and the lesion extent is accurately delineated, EMR can be a curative treatment. And in a practice of EMR, the markings are usually put just outside the lesion, whereas the marking is made a few millimeters away from the margin in ESD. We select the snare according to the tumor size and the purpose of resection. Basically, a large snare makes it possible to resect a large lesion en bloc, but maneuverability is sometimes not good and chance of perforation can be increased. For small lesion, or in case of piecemeal resection, we select a small snare. I explain some technical tips of EMR. As same as biopsy, the lesion is better to be positioned at the working channel site. And when you snare the lesion, it is better to fix the tip of the snare at the distal side of the mucosa, and the snaring over the lesion. So this is an example. After injection of the solution, our junior colleague initially tried to remove the lesion with a snare. So he put the snare across the folds, and then tip was not fixed, and just pressed down the snare toward the lesion. So it was a bit difficult to capture the mucosa. And then at this time I took over and fixed the tip to the distal mucosa and tried to open the snare along the folds, and then slightly suction the air and capture the mucosa. So we could achieve unblocked resection for this lesion. Recently, evolutionary type of this technique is reported as a tip-in EMR. In this method, small mucosal slit is created with a electrical cautery, and anchor the tip to fix the tip of snare to facilitate large mucosal resection. Another technical tip is not to inject the solution into multiple times. It may cause large flat elevation and make the snaring slippery. So I try to create one elevation and make the lesion located at the top of the elevation to facilitate snaring. So this is a laterally spreading tumor with biopsy scar. And sometimes when we make diagnosis this as adenoma, we puncture in the central part of the lesion and try to create one elevation and fix the tip of snare and capture the lesion. So this lesion can be removed completely, could be removed completely. Next, I want to explain about cold snare polypectomy. For cold snare, several dedicated types of snares are available, and we prefer to use hot and cold hybrid type snare in our practice. So for such small lesion, smaller than 1 centimeter, open the snare and capture the lesion with surrounding mucosa and close and chop it off. Then I would like to introduce underwater EMR, which replaced oral practice from injection EMR to underwater EMR. Principle of this method is derived from EUS images. So under the water, mucosa and submucosa is protruded into the lumen, but the mucellari's propria is stay circular behind the submucosa. So when we capture the mucosa, chance of perforation does not increase so much. And I want to explain some tips of underwater EMR. When there is air in the same or another part of the lumen, the air pushes the water away and it is difficult to submerge the lesion. So before the procedure, it is better to collapse all the lumen and infuse the water. So in this case, even though the lesion located at the opposite side of the gravity, water is stay and we can submerge the lesion. Another tip is the same to the injection EMR. We try to fix the snare at the distal side of the mucosa. And we often use torque of the scope and crimping the lesion and the surrounding mucosa into the snare. And this is example. So lesion has flat extension next to the polypoid lesion. So we put marking at the flat part and then submerge the lesion into the water. So under the water, even flat part is protruded into the lumen and we capture the lesion with a snare and cut it. And the surrounding mucosa remains soft because there is no injection, so it is easy to put clips for the resection wound. This is also another good point of underwater EMR. In this lesion, polypoid part was already removed by EMR in the previous physician, and only flat part was remain like this. And we place the marking with the tip of the snare and fix the tip and slightly suction the water. So in this case, marking can be acts as an anchor, and we capture the whole region along this marking. Even this type of very flat lesion with scar can be removed and blocked. An underwater EMR also works for pedunculated polyp. In the air, polyp is attached to the surrounding mucosa, so it is sometimes difficult to pass the snare at that part. But under the water, the polyp is floating up into the luminal center, so it is easy to pass the snare along the head of the lesion. And we can easily capture the stalk like this. In a prospective randomized control trial, underwater EMR provided higher R0 resection rate of 70% and unblocked resection rate of 90% for size 10 to 20 mm colorectal polyp compared to injection EMR. The procedure time and adverse events rate were similar between the two groups. Underwater EMR is also useful for superficial non-ampullary duodenal adenoma. In our study, it provided non-recurrence rate of 97% at the 1-year follow-up endoscopy. We experienced 4 recurrence cases, but they were all managed by endoscopy interventions. For example, there is small recurrence after underwater EMR at this part. In such region, inadequate injection makes lesion snaring difficult. But underwater, we can snare such small lesion just next to the scar effectively. Next, I explain the cap EMR. We use transparent food and crescent snare for the procedure. And we usually create pre-loop before the resection. But at this moment, it is important to place this spike part at the tip of the sheath like this. So this is the superficial squamous cell carcinoma. We identify the boundary of the tumor by magnifying NBI. And iodine chromoendoscopy, and place the marking around the lesion. And after the injection, we create the pre-loop. And at this moment, it is better to place the spike part shaking and place the spike part to the tip of the sheath. And usually distal mucosa come into the cap, so it is important to fix the proximal margin at first and then suction the mucosa as much as possible. And confirm we didn't capture the muscularis propria. And then after that we cut the specimen. So in this method, we can remove about 2 to 2.5 centimeter specimen. Therefore, in our experience, unblocked section rate of cap EMR for lesion smaller than 1.5 centimeter in size is as same as ESD. At last, I explain band EMR for rectal or duodenal neuroendocrine tumor. Before the resection, we usually confirm the lesion is confined to the submucosa and there is at least white line in between the lesion and the muscularis propria. Because ESD often causes burning effect to the bottom of the resection margin, so it is often come back as a vertical resection margin positive in this type of tumor. So we prefer to perform band EMR for net smaller than 1 centimeter. So we put the band suction so that the band is go underneath the tumor. And after that, we open the snare and resect the mucosa underneath this band. In summary, EMR is an effective method for resection of small to intermediate size intramucosal lesion. Understanding of proper indication and basic technique is important to increase unblock resection rate. Careful procedural diagnosis is as important as resection technique. Thank you for kind attention.
Thank you, Dr. Noriya, for this wonderful presentation on techniques of EMR. I think we have now heard the expert from the East speak, and now let us go ahead with the expert from the West. May I invite Dr. G.S. Raju to give his presentation, please. Dr. Raju, over to you. Just before you begin, we will take the questions during the discussion session. So audience, I request the audience to kindly hold on and have patience, and also please put all your questions in the Q&A box rather than in the chat box so that we can address all these questions.
Thank you, Amol. You can see my slides?
Yeah, we can.
Okay, thank you. All right. Thank you, Amol. Thank you, Truptesh. At the outset, I should share that the West actually learned from the East. And whatever I've learned over the years, I want to thank my friends from Japan. So these are my acknowledgements. And what I would like to do is I would like to take you through a case so that we could dissect the case and learn. So this is an 80-year-old woman who has had several colonoscopies for removal of multiple polyps. And she was referred to us for endoscopic resection of a polyp that was incompletely resected. Of note, she has a very long and tortuous colon, and the previous colonoscopist had a tough time. He was not able to keep a stable position of the scope. And when he resected a particular polyp, he was unable to even document the polyp with a good photograph. And she was a very small frame lady with a thin build. So when you see a patient like this, how do you plan the procedure? There are several different things you need to keep in mind. And as part of the procedure, this is an elderly woman, 80 years of age. You have to include in the consent process the risk of a stroke or a heart attack based on the work that was published from Stanford in gastroenterology. So the risk of stroke and heart attack increases significantly when you have an 80-year-old undergoing a colonoscopy. And when it comes to the colonoscopy preparation, think about the functional capacity of the patient, and make sure that you have a relative to stay with the patient so that they don't have a fall trying to rush to the restroom. And we have been, all of us have been using the split dose, nothing different. And also, when it comes to planning your procedure, keep in mind the phenotype of this particular patient. She was small frame, she had relatively flat abdomen, and the previous endoscopy revealed a very long tortuous colon, and the endoscopist had a difficult time keeping the scope stable. So in other words, it is going to be a technically challenging colonoscopy. So with this in mind, you want to plan your procedure for at least 2 hours. That's what I've done. And I reach out to my anesthesia and ask the anesthesia group to put the patient under general anesthesia and paralyze the patient so that the polyp in the transverse colon doesn't move up and down with every breath. So that is something important to keep in mind. And you could start with a pediatric colonoscope or even a slim colonoscope, given this patient's narrow caliber colon. And whenever you think about a long tortuous colon, you want to go into the colon using water immersion technique so that the colon doesn't expand with the insufflation of CO2 or any gas. And for every one interested in EMR, try to get to the cecum in 60 to 70 centimeters. That's one thing that I suggest and recommend highly, because when you get into the cecum with 60 to 70 centimeters, you have much better scope tip control. So these are all the things that you want to keep in mind as you want to set up your practice to take up EMR. So then when you see the lesion, you want to evaluate the lesion using what all you have on your scope, using white light, NBI, and also get into the habit of using near focus. And let us talk about these things. So here is a lesion. We looked at under white light. And as you can see, this is a relatively flat lesion. There is a little bit of scar from prior cold snare resection. And this fold is a little bit thicker. And there is slight flattening of the surface. Then you go and look under NBI. Again, you see the same features. But when you use the near focus, what you notice is, compared to the vessels here, the vessels in the center are a little more thicker and a little more irregular, like the ones that Noriya has shown us about how to identify early dysplastic lesions. So this is a feature that should make you worry about the possibility of an advanced pathology, not just an adenoma, but a little more advanced than that. So when you have a lesion like this with these features, I would suggest that whenever you have suspicion for cancer, even though the lesion is small, do not get into a simple cold snare or a simple hot snare, because you want to look at the deep margin also. And if you want to look at the deep margin, you should lift the lesion with submucosal injection and try to do a good resection so that the pathologist could have a better definition of the deep margin. So no cold snare, no simple hot snare, but try to go with some form of injection to lift and then resect. So when it comes to steps in EMR, there are only 2 steps, inject and cut. And when it comes to injection, we have been actually setting up a program to train the endoscopy techs as part of an endoscopy tech training program in Houston, working with the community college. So when you want to train a tech, which is essential for EMR, you want to make sure that they prepare the saline syringe with a sky blue color solution, that is indigo carmine or methylene blue, to give a sky blue color. That's the easiest way. And make sure they prime the catheter, very important, and make sure they know how to hold the syringe down so that they don't inject some air when they don't hold it properly down and instead holding it up. Once the needle comes out, get into the habit of priming your catheter. I've made these mistakes when I asked somebody to inject and they didn't prime the catheter. I started injecting air into the submucosa. So there are a few things that you don't want to do when you want to get a good injection. So that is, you have the lesion here, you bring the catheter out. Don't tell the assistant to push the needle out and inject. What will happen is the needle will go through and through because the colon is pretty thin. And then you inject all the fluid outside if the assistant doesn't keep telling you how much he has injected. So you don't want to get into this. Instead, you want to make sure that you take control of the injection. Take control of the injection by taking the first step. Once the catheter is out, under vision, ask the assistant to pull the needle out or push the needle out so that you see the needle out, and then make a gentle puncture into the submucosa. And once you are in the submucosa, you ask them to put in a little bit of fluid and then use dynamic injection technique by lifting the lesion as the injection is happening so that you get a good lift. That's very important. So what happens in the outside? So here is your assistant with the catheter. You already got the needle out. You make a small puncture and then ask the assistant to tap on the plunger. Why tap? When you tap, only small amounts of fluid gets out. You're not going to deposit 10 cc's without your knowledge. So tap allows you to have a small amount. And then when you see the submucosa lift, then he can inject. And as the injection is happening, you get a submucosa lift. You can actually look up slowly and pull your catheter back. So you get a good dynamic submucosal injection. So let us look at how did we do this here. I must say here, I used a little bit of a combination of underwater technique, but I didn't just do a snare resection underwater. I tried to inject here. The reason I wanted to do underwater was I had a lot of difficulty to maintain the scope position in this area. I was constantly falling back. So that is something to keep in mind. So here is a lesion. And here is the scar that you can see. This is not a big lesion. And we have already determined that this is a high-risk lesion. So I make a small puncture. So small puncture, nothing. Now we got into the submucosa. And then At this point, I tell the assistant to keep injecting and keep telling me how much has gone in, 1 cc, 2 cc, 3 cc, so that you know how much is being injected, because you can't focus on what the guy is doing while you're focusing on the screen. So once you have a good lift, then you can get your snare out and resect. So before you do your injection, or before you even get your catheter into your scope, make sure you have your electrosurgery setup ready. You have the returning electrode typically placed in the right loin, so you have a shorter distance for the current to go. You make sure that your foot pedal is close to your feet. It's not that the assistant is trying to find the foot pedal once you've injected, because the fluid will dissipate. And make sure that your monitor, the electrosurgery monitor, is in front of you, not behind you, so that if it is in front of you, you can see whatever settings are being used. And it's important for the assistant to tell you, like a nurse giving a drug, right? You have to have a closed loop communication. You should say, we are set at endocut Q, effect 3, duration 1, interval 3. So that's the setting that I use. And on the right side, you have the coagulation. The left side is your cut. And this goes with the yellow pedal. The coagulation goes with the blue pedal. I have recently started changing this thing to soft coagulation and have endocut and soft coagulation, so that if there is a bleed, I can easily control a bleed with my soft coagulation using the blue pedal. So let us look at how do we resect this lesion. Noriya has actually beautifully demonstrated the principles of resection, of controlling the snare, and having a good capture of the lesion. I really admire the way he teaches. So here is a stiff snare, and you want to pick the right snare. Small lesions, better to pick a small snare. Here we picked a 10 millimeter snare, a braided snare, a stiff snare, so that you can actually have better control of encapturing the whole lesion. And make sure that you have all the electrosurgical setup ready so that you don't waste time. And you use your endocut and cut. Cutting is very simple. When I try to cut the polyp, I take the handle of the snare into my hand and I squeeze as tight as possible, almost to the point of almost cold cutting, and then apply the cut current. It cuts quickly. I want to cut quickly. I'm not worried about bleeding. I'm more worried about prolonged cut causing deep thermal injury and delayed post-polypectomy syndrome and perforation. I want to cut fast. So squeeze to the point of cold cut and just apply a little bit of current to cut it. And you can also see that I'm actually trying to get this thing a little bit out of the way to cut it. And you notice that I'm also using a lot of water to stay away and then cut. Once you cut, what do? You look at the base. You want to make sure that the base shows submucosa and not a deep extent of injury. So I want to share a few principles that we have learned from the Australian group, Michael Burke's group. What they've shown is, once you resect and you see nice, meshy, blue-stained submucosa, that's a beautiful resection. You don't have to worry about any delayed complications like a perforation. Here, still see submucosa, but it is a little bit of a deeper plane, and you see the muscle bundles through that. And if you have a muscle injury or a deeper muscle injury, these are the ones, or a perforation, these are the ones that you need to close to prevent delayed perforation. So here, let's talk about this lesion. Although the lesion margin looks good, I've been for the last 15 years applying APC routinely to the edge to cut down the risk of delayed recurrence. So the settings that I use are a forced APC. That's the type of APC that you use. You have different types of APC. Forced APC, 35 watts, 0.8 liters of flow, and apply it around the edge till I get a brown effect, not just white. That's the process I've been using routinely for all my patients. And I try to go along the edge and treat the edge. I don't normally treat the base, but I treat the base if I've actually had multiple resections and there's an overlapping white area, but not a polyp, to cut down the risk of recurrence. So with this protocol, what we have shown is the recurrence rate is pretty low. If you look at the older literature, recurrence rates are around 10%, 15%. But if you do a resection, make sure the resection is clean and ablate the edge, resection rate, recurrence rates could be as low as 3 to 4%. And we have shown that in our own experience. So this is how we do the APC. And then as you do the APC, you also want to document. Normally, when I do an EMR, I have at least 20 to 30 images to tell the whole story from the beginning to the end. Because when you go back to the patient or to your referring physician, he can see what you have done. So I do take a lot of images. So the next is clip closure. And how do you close a defect? There's lots of studies. Even there's a good study recently from Michael Burke, I believe, that came in Gastro, where they've shown that by closing the defect, you cut down the risk of complications. So how do you close a defect? So you can close the defect, and here the defect closure is superficial. And what I mean by superficial is you see the gap between the two blades of the clip. And these clips are going to fall off. You will not have any protection from this clip closure. Instead, you want to close the clip and approximate deep. So what happens is when you close a clip, every clip as you close retracts. And you want to compensate for that retraction by either moving the scope forwards a little bit or the clip forwards by just a few millimeters, so that when you close the clip, you get a deep approximation. So as you can see here, that is a deep closure, and those clips are going to stay. If you actually close the defect like this with deep approximation, you will have the assurance that you have done a good job, and your chances of having a problem in that defect is going to be very, very low. So we have shown that by clip closure, and others have done in randomized control studies, that your delayed complication rate has come down from 10% to 3%. So as you can see here, how deep we are closing. And finally, how do you apply a tattoo? So this is the technique that people have described, but I want to show you. First is I take a syringe of saline, flush the injection needle, and then I take the spot or whatever tattoo that you're going to use, and then inject until it comes up to here. And then you have saline for about 1 cc. And then once you have a saline filled catheter and a little bit of tattoo in the back, it will allow you to create a saline bleb first, and then you fill that bleb with the tattoo as you continue your injection. So You want to keep your saline first and then fill it with tattoo. So by doing this, you'll have a nice clean spot or a tattoo placement, and you want to place it 3 centimeters in the same plane distal to the polyp resection. So you want, and then take a picture of both the things so that it helps you follow up your patients. So coming back to this case, the pathology showed a well-differentiated cancer. Peripheral margins were clear, deep margin was clear, but the deep margin was less than 1 millimeter. So that's an indication for surgical resection as per the previous reports. And then there is no lymphovascular invasion. So although this is a favorable pathology, this is still a little bit worrisome. So in addition to this EMR, we resected about 16 serrated polyps in this patient during the same intervention. Because she's 80 years old, you don't want to bring her back. She has a family history of cancer. So that's what we did. And because of the pathology, we sent her to surgery. They did a CEA, they did a CT, and negative. And the surgeon said, yeah, you need to go to full thickness resection. And my colleague, Philip G, does a full thickness resection. And we talked, and I said, hey, this is going to be a very technically challenging full thickness resection. She has a very long colon, difficult colon, narrow caliber colon, and then putting this big device, we'll have trouble. So we deferred, and we're going to follow up with another colonoscopy in 6 months. So what are the take-home messages? EMR, when somebody refers, try to see the patient so you can actually do a much better job so that you can plan the procedure. And if you're not doing general anesthesia for your EMR, unless you're doing it in like in Japan where you have, you can keep patients awake. I used to do that, keep patients awake, ask them to hold their breath when I'm trying to do a resection. But in the US, if you're using total intravenous anesthesia, go for a general anesthesia and ask the anesthesiologist to paralyze. You have a stable operating field. You'll do a much better job with that. And whenever you see a polyp, get into the habit of assessing the polyp before resecting. Because if you assess and you think there is a high-risk feature, even the polyp is small, you would at least not get into a mess by taking up cold snare. Instead, you go for the EMR, which will give you a better opportunity. For those of trainees who want to learn EMR, I want to share some opportunities with you. For the last 10, 12 years, I've been posting videos, especially for the sake of trainees. And you can watch those videos. Unfortunately, most of the videos don't have audio, but into the future, I will make an attempt to think through and put an audio commentary. Thank you.
Thank you, Dr. Raju. That was an excellent talk. And trust me, I have been the maximum user of your YouTube videos. And as usual, Dr. Raju has been a maven of illustrations and video editing. It's a pleasure to watch both Dr. Raju and Dr. Noriya do their presentation. It's a great learning. So now I'll hand over to Dr. Rajvinder Singh to initiate the moderating session.
Thanks, Truptesh. I suppose thanks again, Amol and Truptesh, for the kind introduction, and Noriya and Raju for very nice talks. We should start off with a couple of cases and then go on to discussion, if that's all right with everyone.
That's fine, Raj. We'll go with one case from you and then one case from Aasma, and then take it up accordingly. And we also have quite a few questions. We'll probably also mix up some of the questions during the during the discussion. So let's go that way.
All right. Thank you. Thanks, Amol. So I'll just put up a case, and then we can discuss about this case and take things further. So this is a case of an 85-year-old who presented to us with some evidence of rectal bleeding. And also the patient was on anticoagulants. So the patient was on apixaban as well as antiplatelet agent, Coplavix, and had this lesion in the hepatic flexure. So I guess the question is that what should we do with this lesion? So you may have noticed that there was possibly an area which was slightly depressed in that lesion itself. It measured perhaps about 2.5 to 3 centimeters extended across a fold. So I guess our options could be perhaps biopsy the area which was most abnormal, try to perform some form of an EMR, be it a cold snare, hot snare, underwater EMR, or perhaps ESD, or maybe even leave the patient alone. So just before we go through that, I'd like to make a few points to sort of conceptualize things. So before any EMR, I think it's important for us to look at the lesion from afar, and then to also try to image areas which we think we should focus on, areas which are abnormal. And we have to try to work out if the predicted histology, indeed what we are, approach it with the appropriate treatment strategy. All right, so it could be an SSL, a TA, a TVA, a superficial cancer, or deep invasive cancer. So this is all important. And it's important to understand one of the classifications for the colon, at least using this JNET classification is one way of doing it. And perhaps look at the vessels, the surface pattern, and what's the most likely predicted histology. So that's type 1, 2A, 2B, and 3. I won't go into detail, but just to let you know that just like anywhere else in the GI tract, it's important to look at the vascular pattern and the pit pattern, looking at whether it's regular or irregular, or in the type 3, whether it's amorphous and totally non-structured and destroyed. We also need to understand this concept of covert cancer, and what is covert cancer is basically if there's no obvious mucosal features to suggest that there's submucosal invasion, for instance, a Kudos type 5, NICE type 3, JNET type 3, or modified Sano 3B. And if there's depression which is excluded, then we should sort of think of tackling the lesion based on the risk of invasion. So you have a 2A granular lesion, the risk of submucosal invasion is very low, less than 1%. And when it's non-granular, sessile, and located more distally, then the risk of submucosal invasion increases, especially if it's sessile, non-granular, and in the rectum up to 22%, as you can see there. So that then changes our strategy. Basically, with those sort of lesions, we should try to remove them en bloc. And that, of course, is dependent on the size of the lesion as to how we want to tackle it, whether an EMR or an ESD. Or if it's flat and granular, perhaps a piecemeal EMR strategy is warranted. So once we do that, we can then sort of address the lesion based on the tools and techniques which we have. So I just touch upon cold snare EMR to say that it's ideal for sessile serrated lesions, especially, and there's data which is building for flat TAs and TVAs. Obviously, we have to ensure that there's no submucosal invasion and there's no abnormality in the pit pattern, as Dr. Raju showed in his video. So coming back to this lesion, you can actually see that there is some sort of granularity. We know the size of the lesion. We know it's a flat lesion. And it's important to try to look at the area which is depressed. There was some suggestion that that area was not quite right when we looked at an overview sort of method. And just spending a bit more time, we can actually image the area, and you can see very nice pit patterns in keeping with what is a tubular adenoma. So we are happy with that. And in this instance, we elected to perform a cold snare EMR. just like what Dr. Raju had suggested, what we tend to do in this instance is to inject, but to do this in a sequential manner. So inject and resect. So we don't inject the whole lesion. As Dr. Uedo mentioned, the snare can then slip if we inject the whole lesion. So in this instance, what we do is we sequentially work from one edge to the other edge. That basically ensures that we capture the tissue which we want. And if we're not happy with the tissue which is captured, of course, this is a cold snare technique. And what we would do is then we would capture even more tissue. For instance, you can see that in part of this video, the edge is showing a bit of adenoma, and we go after it and remove it in that sort of fashion, obviously using the flushing function within the scope itself. And as we move slowly across, this video is actually not heavily edited, and the whole procedure took us about 10 minutes to do. So we're slowly moving across, and you can see the water pooling there. The snare is still within the channel, and we can also suck the adenomatous tissue to the side of the snare. So I'll just move along for the sake of time and show you that towards the end, you can get a fairly good result with careful sequential resection using the cold snare technique. And again, if you're not happy, for instance, in that edge, you can just go and take off a little bit more. So this is very safe. The patient was on quite heavy anticoagulants and antiplatelets, and as a result, with this technique, the patient did not have any evidence or episodes of delayed bleeding. So just quickly, again, the purpose of the injection for cold snare technique is not to protect the deep muscle layer, because no cautery is used, but to loosen the submucosa. We can use a bit of adrenaline or epinephrine, and we use a bit of stains, and that helps to define the border, either methylene blue or indigo carmine. This is the technique which I demonstrated earlier. This is just another polyp where the injection is put at one edge and then slowly working across the other edge. We use smaller, thin, stiff snares, and these are specific snares for cold snare polypectomy. All right, you can use some of these snares, and there are other snares coming into the market. Basically, they are thin wired snares, 0.3 millimeters in diameter, the wire thickness that is. We should not show off the tail of the snare, as that can flip the snare across. You want to ensure that you have got the snare just across where the sort of diamond or oval shape pattern is seen. And then we have to push down the snare, not lift it up, and advance the sheet of the snare as the snare is closing, and we should cut in small pieces. Try to get a bit of rim of normal tissue as well, and again sequentially work from one edge and overlap and repeat the above. There are some issues. If there's a large piece, don't be greedy, try to resect it in 2 pieces. And if it's stuck and you won't cut, you can wait for a few seconds as the snare will slowly transect the polyp. And if you're still stuck, sometimes you can straighten the scope to deangulate and detorque, or to straighten the sheet of the catheter. When you continue to be stuck, then loosen the snare slightly and deflect it from the base to release the excess submucosa and close again. Sometimes we are advised to just pull the snare really hard with force, but I would caution you that sometimes that can lead to a perforation. This is a case where we reported of using the so-called tug technique, and we actually pulled it too hard. You can see a perforation which has occurred, which was closed. So as I said, if the above techniques fail, just simply let go of the tissue and cut it in 2 separate pieces, because you know that the polyp is benign. Some expanding indications, anticoagulants and antiplatelets, which can be used. If you want to look at it in even more detail, you can look at this paper. And sometimes tackling fibrosis as well can be used using the snare technique. In this instance, this lesion was in the duodenum, which was removed using a cold snare technique. So it's fairly a safe technique. So there's comfort without cautery, as there's no stress as you get better and better with it. And with time, you will certainly get quicker with it as well. It's also potentially accessible to more endoscopies, and there's no need for prophylactic clips because the risk of delayed bleeding is practically non-existent. So summary for cold snare is that size, there's no limit. As I said, it's very useful for sessile serrated lesions, whatever the size is, and certainly for certain flat granular lesions, there's more and more data coming with regards to tackling these lesions using the cold snare technique, provided there's no high-risk features. Some patients with lots of polyps, you can also use this technique, especially the sessile or the serrated polyposis syndrome patients or patients with FAP. There's also an increasing role outside the colon. And of course, with antiplatelets and anticoagulants, there's increasing role for using these snares. And you can also tackle more resistant lesions. So I'll stop there and get Aasma to present her case, and perhaps we can discuss further. If there's more time, we can do the second case. Thank you.
Thanks, Raj. And Aasma, over to you. We can have your case.
Yes, thank you very much. So, wonderful cases. I think I'll go through my case rather quickly. I'll ask questions as we speak. And then I think there's some wonderful questions in the discussion that I do want to get to. So, this is very straightforward, and I'll throw out questions as we go through this case. This is a 56-year-old coming for surveillance colonoscopy. And this is a case myself and a fellow are doing where we see a polyp, but as on further inspection, it kind of spans a fold and kind of goes underneath. So the questions here for the panel to think about is how you would go about injecting this for maximal exposure. Clearly injecting behind wouldn't be great because this kind of, drapes over the fold and goes somewhat underneath. And would you inject around the polyp, in the polyp, or either? So that's what it looked like. The second question for the panel was, what kind of solution would you use? In this, we used a dilute methylene blue, but are there other options? And then when it comes to resection, we in the US try to use primarily cold technique. Here again, the positioning, if we'd love to hear from the experts on positioning, because clearly there's a pool of fluid here, there's water, air, suction, a lot of elements going on. So what would be an optimal technique? And is this something that could be taken in en bloc versus piecemeal? Here is another thing we commonly see doing these. You can see the submucosal fibrous band show up. What does that mean to experts, and what would you advise fellows or people when they're doing this and they see this fibrous band? And in this case, we're doing piecemeal, like was just suggested. And is that what alternatives would you have considered in this case? And after it's completely done, and this is what it looks like, is there anything else the experts would recommend adding, such as along the edges or in terms of clipping? So with that, I will stop sharing, and I think we can open it up to discussion.
Okay, I think a lot of questions, Aasma. You might want to ask them one by one, because otherwise I don't think we're going to remember all the questions. But I think your first question was, where do you start injection? So Dr. Raju, you want to take that up? Noriya? Maybe we'll have Noriya after Dr. Raju.
I think before I go to the injection, I will, if the patient is being done by under anesthesia, which I expect, I think probably a lot of us are doing, I will ask the anesthesiologist to put a nasal trumpet. Because if you see the movement of the colon up and down, up and down, up and down, all right, I'm trying to struggle to get my needle there. It's going up and down, up and down. That's what I tell them, hey, make sure you open up the airway so that the patient is not breathing up and down, or not too much of colon movements. That is something I would like to share. In terms of the injection, I always try to think about my operating field in upper 1/3, middle 1/3, and lower 1/3, like a photographer thinks about, and bring the lesion to the lower 1/3 to middle 1/3 junction. That's about where I would like to bring, and try to inject distal to the lesion, always onto the cecal side or the appendiceal side of the lesion. And then this is not a big lesion, so I should be able to inject one place and get a good lift. That's how I would like to do. I try to use saline. I've not used anything else in the last 15 years except saline with a little bit of indigo carmine. And that's what I do. But with that movement, I worry about my injection needle going through and depositing a lot of fluid outside, although it's not going to cause any problems, but it's better to get help from the anesthesiologist to get a stable field. That's what I would do.
Right. So
I think in addition to what Dr. Raju is saying, as Aasma has also done it before, in the United States, we use a solution called as Orise, which is a product of Boston Sci. Not that they've supported this webinar, but that's what we use in our unit, and it's pretty helpful. It has a good sustaining power. It stays for a while, and at least have a good distinguished look of the polyp and the demarcation.
well, Truptesh, we've used it for ESD, but I'm not sure whether we should use it for EMR because it makes the submucosa a little bit tough. So it's the submucosa doesn't remain that supple that you want your snare to cut through when you've got a viscous gel inside that. So that's my feeling. I don't know what the experts would want to comment on that, but I feel, I would rather go with saline for EMR unless it's really extensive, where sometimes we use gelofuscin that also diluted.
Can I comment? So initially, I have no experience of Orise, but initially we used Mucosal, sodium hyaluronate for conventional EMR, so that as Amol mentioned, it creates really hard, round, elevation. So sometimes snare go underneath that kind of injection. So it causes very deep resection and sometimes cause perforation. So probably conventional EMR, just saline is good enough in my experience feeling.
Can I make a
That's
comment?
quite interesting because I feel like in the US, we have a very low threshold for using some of these other agents. Perhaps, we're exposed to them more, but that's a good, interesting perspective.
Well, we almost invariably use it for ESD, but hardly ever for EMR. So, but then
Can
our
I-
threshold to convert to ESD is much more. I would say that as well.
Can I make a comment, Amol?
Yeah.
Yeah. So it's totally understandable in this case. A couple of points is that because the lesion is not large and we do not really want a sustained lift, it's probably best to use saline, or if you have gelofuscin in your departments, then to use that, because we're not really wanting that lift to occur for 20 or 30 minutes given the size of the lesion. The other thing which I would comment on is that perhaps because gravity was probably getting in the way in the fluid pooling close to the lesion, perhaps maybe altering the patient's position may have helped, or in the instance if the scope is short, like Dr. Raju mentioned, perhaps allowing the lesion from the 10 or so o'clock position to kind of move or deviate towards the 5 o'clock position to allow for a more easier injection and snare capture. So the lesion itself, just by eyeballing it, is benign. and it's perfectly all right to remove it in 2 pieces like what was done. So I think in the bigger scheme of things, I think everything worked out well. Sometimes we do remove the lesion without an injection on one edge and then use the water pump or the foot pump to try to force fluid into the submucosa and remove the other portion if necessary. Sometimes that could also work if you do not want to inject the lesion.
Dr. Raju wanted to add something.
Aasma, you brought a very good case. I want to share a couple of things. That is, if you actually, this is what I tell the fellows, if you get your act together, you can get away with just simple saline with a little bit of indigo or methylene for removing 20, 30, 40 millimeter polyps without a problem. When I say get your act together, what I mean by that is set up your electrosurgery unit, get your snare out, get your injection catheter out, everything ready, and get your foot pedal where it should be. And then once you get your catheter and inject, it takes about maybe less than 15, 30 seconds to take this catheter out and then put whatever instrument to do this. It's not. I must say that a lot of people have done these studies in animal models and said, hey, this is going to lift and stay there for 15 minutes. You don't need 15 minutes to resect polyps, right? We know that, polyps can be resected very fast if you have your act together. And those studies have actually prompted everybody to go and say it's a good branding and marketing gig, but you don't need that type of viscous solution for most polyps, especially in the United States, where we do a lot of screening. And most of the polyps that we see, Aasma knows this, are small. They're not the big polyps that we see. Most of the large polyps are seen in countries where they don't have screening population. I want to hear Aasma's thoughts on that, because, that's something to keep in mind,
Yeah, no, I totally agree with you. So I think it's more of just enthusiasm rather than, what's truly needed. So it's definitely way too much. I wanted to ask both our experts about frequently with polypectomies, this submucosal fibrous band that you saw in that particular case, and what that means to you, and what you tell your trainees about it.
I think at least we know, right, from the articles published in GIE that white is muscle, and the white thing that you're seeing after cold snare is muscularis mucosa. So you tell them that it's muscularis mucosa, nothing to worry about. But at the same time, I tell all my trainees, document what you have done. We don't do this well, actually. I don't think we actually as a society have done a good job saying that we need to document what we have done, right? Every polyp that we cut or remove, I tell them that take a photograph to document what you've done. That's one of the things that we have as a society not done a good job. Right? A lot of times you see polyps, you see a polyp photo, and then the report saying that there is resection done, but you can't see a photo showing that the polyp resection was done and the margin looks clean and the base looks clean. And that's something to keep in mind. Get into the habit of documenting the story of a polyp from the polyp to the resection.
Right. So I think thanks Aasma for that wonderful case, and thanks Raj for that wonderful demonstration and this thing. But let's start with the cases. I think there are plenty of questions that are in the chat box, and we need to start with some of these questions. So Dr. KK Rawal from Rajkot, India has put forth this question, that should underwater EMR replace all conventional EMR? Now that's a question for both Dr. Noriya, Dr. Raju, and also Raj and Aasma. What is your take on this?
Difficult to say it's not be should, but but actually in our practice, underwater EMR really replace probably more than 90% of our procedure. We don't inject much. So, and as I show that it improve RZ resection rate and unblock resection rate, especially it is intermediate size. Probably we can expand the size until 3 centimeter. So in our practice, we completely changed the practice.
Okay, so what does the West think about this, Dr. Raju?
I think that to me, the way I look at it is, this is the way I look at it as a philosophy. The philosophy is, patient comes, you tell them that you're going to get the polyp out safely and completely. Safely, so that the patient goes home. Completely, so that he doesn't keep coming back. Whatever you do, as long as you can do that. And then now going green, you want to say, I want to save the Mother Earth. So try to figure out and develop those techniques so you have different techniques under your belt. It's not about one or the other. Sometimes you may not be able to do a particular technique. You should be able to apply the different technique. But I tell all the fellows, hey, what is the goal? You want to send the patient home without getting them admitted. And you want to send them home so that they don't keep coming back with recurrence of polyps. So those are the two things that I keep in my mind and I share with my fellows, a safe cut and a complete cut. Whichever technique can get those results, apply. Whatever is easy for you, apply.
Thanks, Dr. Raju.
I agree with that. Underwater EMR, I find helpful. One, like Dr. Raju said, it's a skill you should know, but particularly in the proximal colon and for lesions that look like sessile serrated lesions, I find it helpful, just kind of looking at the margins and distinguishing them from normal mucosa. But I think we should be using both techniques depending on the case.
All right. So we have last 15 minutes left. I would go with a quick fire round. What are the indications of applying post-EMR clips? Is it determined by the depth or the size of the defect? Open to the panel.
I think,
Raj, you want to take that?
Yeah, look, one of the most important determinants of using clips obviously is the patient itself. And if we know that the patient is going to be recommenced on any of the antiplatelets or anticoagulants, then I think in that instance, you would probably err on the side of caution and try to close the defect. We have shown in data with regards to the large polyp study from Australia that right-sided lesions have got a twofold risk of a delayed bleeding compared to left-sided lesions. So about a 11 to 12% chance of delayed bleeding versus 5 to 6% in the left. So if one were to face with lesions in the right colon, then it may be worthwhile to try to close the defect with clips. I think these are the two main indications. But again, given that we have also spent some time on cold snares, it's also good to know that we've got yet another tool in our armamentarium, and we can use cold snares to sort of mitigate that delayed risk. Intra-procedural bleeding is not much of a problem. We normally just use the snare tip. And as Dr. Raju mentioned, with the soft chloride current, you just zap the area which is bleeding and continue on with your EMR. So it's more of the delayed bleeding which we need to be cautious of. And I may just add, it's not a battle between cold snare, hot snare, underwater EMR or ESD. It's actually using the right tools and techniques for the right polyp, and to use what one is most comfortable with rather than using one technique over the other.
Right. Thanks, Raj. So, Noriya Mohan Ramchandani asks, can we do a piecemeal EMR in large but superficial esophageal cancer or gastric lesions as we do for a granular LST in the colon? So that's Mohan's question to you.
Oh, so it's also depend on if one has a technique of ESD, especially large region, multiple piece always increase the chance of recurrence. So if he or she has a technique of ESD, it is good for large region. But as I mentioned, if the region looks intramucosal and all intramucosal, I think piecemeal EMR is good alternative to ESD. So if the ESD technique is still not so prevalent, maybe we can apply. Most important thing is we have to predefine it is really intramucosal or not.
Okay.
So,
Thank you.
yeah.
Right.
Yes.
So, Noriya, just a minute, Truptesh. So, just to continue with that question, I had a question myself.
Mhm.
What is the threshold for you to convert or to choose between an EMR to ESD? And does it depend on the size of the lesion or the morphology of the lesion or the histology or location or all of that? And I think we should stick to colorectum rather than putting across everywhere in the body, because otherwise it'll be a too long a discussion. So just in the colorectum, what is it that you choose?
So basically, even ESD or EMR indication is, region with a very low risk of lymph node metastasis. So maybe intramucosal lesion for depth, intramucosal lesion, or still suspicious for shallow submucosal invasion. So that is both indication for EMR or ESD. So probably our indication is usually size and maybe location. Colon lesion, especially proximal colon, ESD is a bit difficult and dangerous. So sometimes we prefer to perform piecemeal EMR. But rectal lesion, even though it is small, it's very easy to perform ESD. So we prefer to do unblock resection. So lesions smaller than 2 centimeter, it means the size of snare. We definitely perform EMR, underwater EMR, or conventional EMR. Yes.
Thank you. This is a question for Dr. Raju. After cold snaring, how long should we wait for the bleeding to stop spontaneously before considering any endotherapy?
Usually, if you think about cold snaring and watch, most of the cold snare bleeds stop. And if it continues, you can do a little bit of water jet to put some tamponade effect with the water jet. And if it, if it is a capillary ooze, it stops. If it is a brisk bleed, if I'm worried about it, I would just put a clip. I can't tell you what's the time, maybe a minute or so. Most people don't have a lot of patience to keep waiting there, right? So.
Thank you.
Thank you. So there's another question, I think 2-3 questions which are looking at snare tip coagulation versus APC as to reduce recurrence after EMR. And so what is your take on that? What should one use? I think Rajvinder over here would say snare tip. Dr. Raju mentioned about APC, so we would like to hear from both the experts as to what to use when.
I think if I may say again, the reason the snare tip came into practice is because of purely because of convenience and possibly cost-related issues. So you already use the snare to remove the polyp using the hot snare technique. So I guess the snare tip becomes another sort of tool using the same device, or another technique using the same device. What's key with all of this is to ensure that one is forced to look at the margins of the lesion, and to ensure that there's no recognizable adenomatous tissue. And given that our scopes are now much, much better with regards to the definition and the clarity, it's good practice to do that. And once we ensure that there's really no tissue, then an STSC technique, which could be quite convenient, could be the way to go. But I don't doubt that even the APC technique is sufficient as well. It's again what one is most comfortable with.
Yeah, I think first of all, I want to congratulate the Australian group for thinking about the snare tip soft coagulation. It's a beautiful concept. The reason I stick with APC is because I started using it since 2008 and as like a prospective study. And I wanted to stick with it to see what happens. Sometimes, you can do a little bit of a cohort type of study to figure out. And I was pleasantly surprised when I looked at my data in 2003, 2014 or 15, to notice that at 6 months and 18 months after the resection, the recurrence rate was so low. And I just thought that maybe there's something wrong I'm doing, or I'm not biopsying it properly or whatever. But now it's now 14 years. I still see very low recurrence rate. And if somebody says, hey, what should you do after resection? I say that you should ablate the edge. In terms of how to ablate the edge, document first, taking multiple photos of the edge, that there is no macroscopic disease, right? That's what Raju is saying, right? You cannot ablate in macroscopic disease. You have to see normal round pit pattern at the edge. And once you see that, then ablate with a snare tip soft coagulation, 80 watts or whatever. And they've shown that recurrence rate is pretty low. And that's something to keep in mind. Sometimes what happens is in certain situations, APC is a little bit easier to apply. You don't need to be able to touch that surface. And what I don't know is with APC, you get a whitening. With a snare tip soft coagulation, you just get a very superficial whitening. What we don't know is that whitening sufficient that the injury goes deep into the crypt base where the dividing cells are, or should you get a brown effect so that it's a deeper thermal injury? We don't know that. And Mohan asked the question, is there a control study between APC versus snare tip soft coagulation? I'm not aware of that.
All right, we have our last 60 seconds. I have one question to go and then we'll wrap up. This is for the entire panel. Is there any standardized protocol or procedure to handle perforation during EMR as our guidelines?
There is a deep muscular injury classification that was meant to be the second case which we could put up, but we have run out of time. So if one were to go and look it up, there's a 5-step classification. Basically, DMI types 3 to 5 basically would warrant one to close the defect, as Dr. Raju briefly showed in his presentation as well. Whenever you have suspicion of muscular injury, or the muscle has been breached, or the wound itself has been contaminated, then obviously the best strategy at that point is to clip the area.
Thank you.
Yeah, I would
Thank you,
add
everybody.
to that. I think recognizing the target sign is very important for all, because that's something you'll see much more commonly than a frank perforation. So recognizing it and knowing what to do to manage it is very important.
Dr. Raju.
I think one thing is we have learned a lot over the last 15 years. I think we've learned a lot from. I think most of what we learned is from the east side of the world. Get into the habit. Once you close the snare, see what is happening below the snare, and if there's a lot of tissue getting entrapped. And if you have a doubt in your mind whether you trapped a muscle, loosen your snare, distend the colon. And that simple trick would allow the muscle to fall back. And then you tighten, and as you're tightening, watch again. And if you're in doubt, you just loosen the snare till it falls back. The other thing that is very important is when you're cutting on the right side, go with a smaller snare so that you don't entrap bigger areas of tissue, so that you avoid getting into trouble. Those are the simple things that you could do to not get into trouble and then go through that anxiety of dealing with a perforation.
Excellent. Thank you, all the faculties, experts, moderators. You are all experts for us. And it was a 90-minute session of words of wisdom. And thank you to all the attendees to take out time and be a part of this conference. We have more to go. I will hand over to Amol for the announcement for our next upcoming webinar.
Thank you, Truptesh, and thanks once again to all the faculty and to the attendees for joining us for this East Meets West webinar that was conceived by Truptesh and me, and basically in our endeavor to bring together the philosophies and concepts and practices and comparing and contrasting between the East and the West. We now move ahead to announce our next webinar, which will be held sometime in February. And keep watching our space, keep visiting freeendoscopy.com. And if you have not registered, do register for regular updates. The next webinar topic that we have decided upon is on another contemporary topic of global interest, getting the most out of your EUS and EUS FNBs. And we will, of course, have a star-studded faculty to address this question. And I'm sure you will all be happy to join us for this webinar sometime in February, and very soon we will come out with the concrete dates. It will be on a Saturday. It will be at the same time, 6:30 p.m. Indian time, and that would be still be 8 a.m. Eastern Standard Time, because I believe
Yes.
yeah, it will still be that time, because after March we will again move it to 9 o'clock. So that is how it will be. But keep watching the space and keep registering on on the freeendoscopy.com. And also one more announcement, that I'm sure a lot of you all wanted to attend this webinar, and many of your friends and colleagues wanted to attend this webinar, but because of the time constraints and the time zone constraints, not everybody can attend live. So we will, the proceedings of this entire webinar, the 90 minutes, have been recorded and they will be uploaded on the Free Endoscopy YouTube channel, and they will be available for review and to hear the webinar and for the experts to speak. And you can even ask questions after viewing if you have any questions, and we will try and get the experts to answer your questions. So with that, I would like to thank each one of you all for sparing time on this Saturday and joining us for this wonderful webinar. Thank you so much, and let us look ahead to the world of interventional endoscopy, and let us keep growing this world of interventional endoscopy. Thank you so much. Bye bye, and have a great weekend. Bye bye.
Thank you. Thank you.